I want you to think about the last time you bought a pair of jeans. Maybe 20 years ago, you could wear stiff denim, ride a bicycle for hours, or use any brand of laundry detergent without a second thought. But today, maybe the seam of your trousers feels like a knife edge. Maybe wiping after the toilet feels like sandpaper. Or perhaps intimacy, something that used to bring pleasure, now brings a strange mix of numbness and sharp pain. If you are nodding your head, you are likely experiencing the great divide of menopause, the disconnect between your internal reality and your external sensation. We talk a lot about hot flashes and brain fog, but we rarely talk about the fact that the architecture of your most intimate areas, the vulva outside and the vagina inside, changes radically when estrogen leaves the building. Today, we are breaking the silence. We're looking at internal versus external sensitivity, why they change, why they often feel completely different from one another, and how we treat them to get your comfort back.
Welcome. I'm Dr. Emma. Too often, the health needs of women over 50 are ignored or misunderstood. Not here. I have dedicated 15 years to researching the unique biological changes of midlife. I'm here to cut through the noise and bring you the practical, science-backed insights you deserve. Welcome to your best years.
To understand the sensitivity shift, we have to look at the fuel source. The vulva, the external lips, clitoris, and opening, and the vagina, the internal canal, have one of the highest concentrations of estrogen receptors in the entire female body. For decades, estrogen acted as a plumping agent. It stimulated blood flow, it encouraged the production of collagen for stretch, and it maintained a layer of glycogen, sugar, that kept your good bacteria happy. When menopause hits, that fuel supply is cut. But here's the catch. The external tissue and the internal tissue react to this drought in slightly different ways. This creates a confusing sensation where you might feel hypersensitive on the outside, everything hurts, but hyposensitive on the inside, numbness or lack of feeling, or vice versa. Let's separate them. Let's start with the outside, the vulva. The external landscape changes primarily due to the loss of fat and collagen. In your reproductive years, the labia majora, the outer lips, are filled with a subcutaneous fat pad. This isn't just cosmetic, it is a functional cushion. It protects the sensitive inner structures, the clitoris and the urethra, from friction against your clothes or a chair. 1. The loss of the cushion. Post-menopause, we lose that fat pad. The outer lips deflate and thin out. Without that cushion, the sensitive inner lips and the clitoris are more exposed to the world. This is why many of my patients over 60 suddenly find tight pants unbearable or can no longer enjoy spinning classes. The buffer zone is gone. 2. The thin skin phenomenon. The skin of the vulva becomes translucent and paper-thin. This brings the nerve endings closer to the surface. This leads to tactile hypersensitivity. Think of it like a burn victim or a scraped knee. Light touch doesn't feel like a tickle, it feels like irritation. Gentle washing can feel abrasive. This is why over-cleaning is the enemy. 3. Clitoral atrophy and the hood. Then there's the powerhouse, the clitoris. The clitoris itself may shrink slightly due to a lack of blood flow, but the bigger issue is the clitoral hood. As tissue thins, the hood can sometimes adhere or stick to the glans, the head of the clitoris. This traps debris, smegma, underneath, causing irritation, but it also muffles sensation. You might find that direct touch hurts because the skin is thin, but you can't reach a climax because the blood flow is poor. It is a frustrating paradox of pain and numbness coexisting.
Now let's travel inside, past the opening, the introitus, and into the vaginal canal. The sensation change here is different. 1. The disappearance of rugae. A healthy estrogen-rich vagina looks like an accordion. It has folds and ridges called rugae. These folds allow the vagina to stretch and expand during intercourse or exams without tearing. After menopause, as collagen drops, these folds flatten out. The walls become smooth and thin, like a rigid pipe rather than a flexible accordion. The sensitivity result: when something enters the vagina, a speculum, a toy, or a partner, the tissue cannot stretch. Instead of expanding, it tears microscopically. This registers as a sharp tearing pain, often described as shards of glass or sandpaper. Number 2, the pH flip. Internally, your ecosystem flips. A healthy vagina is acidic, pH 3.8 to 4.5. Without estrogen, the pH rises to a neutral 6.0 or 7.0. Why does this matter for sensitivity? An alkaline environment kills off the good protective bacteria, lactobacilli, and welcomes fecal bacteria. This creates a low-grade chronic inflammation. You might not have a full-blown infection, but you feel a constant internal rawness or burning, even when you're sitting still. Number 3, the lubrication lag. This is the most famous symptom. In your 30s, lubrication was immediate. This is called transudate, fluid leaking from blood vessels to coat the walls. Post-menopause, because blood flow is reduced, that response time slows down significantly. You might feel mentally aroused, but your body takes 10 to 20 minutes to catch up. If you attempt insertion before that lag time is over, the friction on those dry, smooth walls causes immediate pain, which triggers a feedback loop. Pain kills arousal, which stops lubrication, which causes more pain. Here is where the internal and external worlds collide to create a problem called dyspareunia, or painful sex. When the external skin is thin and the internal walls are dry, your body learns to anticipate pain. The brain says, "Stop, this is going to hurt." In response, your pelvic floor muscles, the hammock of muscles supporting your bladder and uterus, involuntarily clench. They snap shut to protect you. This is called secondary vaginismus, or a hypertonic pelvic floor. Now, even if you use lubricant, insertion hurts because you're fighting a wall of muscle tension. It isn't just that the skin is dry, it's that the muscles are guarding the gate. This leads to deep internal aching during or after intimacy, a sensation distinct from the surface burning. How do you know which one is your primary issue? Let's do a quick self-check. Signs of external issues: vulvar atrophy, burning when urine touches the skin, itching that wakes you up at night, discomfort wearing jeans or tight seams, pain immediately upon touch or wiping, feeling like chafed after walking. Signs of internal issues: vaginal atrophy, deep tearing sensation during intercourse, spotting or bleeding after sex or exams, a feeling of heaviness or dull aching in the pelvis, yellowish or grayish discharge due to pH change, recurrent urinary tract infections, UTIs. Yes, this is related to internal vaginal health. Most women have a mix of both, a condition medically known as GSM, genitourinary syndrome of menopause. The bad news, these changes are progressive. Unlike hot flashes, they do not go away on their own. They get worse if untreated. The good news, they're highly treatable. We need a three-pronged approach: maintenance, protection, and restoration. Step 1, the do no harm hygiene. External. Your external skin is now fragile. Stop scrubbing. Throw out the soap. Even gentle soaps have a high pH. Use a specific pH-balanced vulvar cleanser or just warm water. Ditch the wipes. Wet wipes often have preservatives that sting microabrasions. Laundry logic. Switch to free and clear detergents. No fabric softener on your underwear. Your external sensitivity is an allergic reaction waiting to happen. Step 2, the moisture strategy, internal and external. We need to distinguish between moisturizers and lubricants. Vaginal moisturizers, these are like face cream for your vagina. You use them every 2 to 3 days, regardless of whether you're having sex. They contain hyaluronic acid or polymers that bind water to the cells. They plump the raisin back into a grape. Lubricants, these are for the moment of intimacy to reduce friction. Pro tip, if your skin is very thin and absorbs water quickly, water-based lubes might dry out too fast, becoming sticky. Try a silicone-based lubricant. It sits on top of the skin and provides a lasting glide that protects that thin external tissue from tearing. Step 3, the gold standard, localized estrogen. This is the game changer. Many women are terrified of hormone replacement therapy because of old studies regarding cancer risks. However, localized vaginal estrogen is different. It comes in a cream, a tiny tablet, or a ring. It is applied locally to the vagina and vulva. Very little, if any, gets into your bloodstream. It doesn't treat hot flashes, but it stays in the pelvis to fix the tissue. What it does, it literally thickens the skin. It brings back the fat pad cushion. It restores the acidic pH, killing bad bacteria. It brings back the accordion folds. It fixes the sensitivity at the root cause. I have dedicated 15 years
Step
to
4,
researching
mechanical
the
therapy
biological
for the muscles.
changes of midlife.
If you have developed
I'm
that
here to
muscle
cut through the
guarding or
noise
tightening,
and bring you
estrogen
the
alone
practical,
won't fix it.
science-backed
You need to
insights you
retrain
deserve.
the muscles to relax.
Welcome to your best years.
Pelvic floor physical therapy. A therapist can perform internal massage to release trigger points. Vaginal dilators. These are graduated silicone tubes used to gently stretch the vagina and teach the brain that stretch does not equal pain. You start small and work up, retraining your sensitivity response. Finally, we have to talk about how to communicate this internal and external reality to a partner. Partners often interpret your pulling away as a lack of attraction. They don't understand the mechanics. You need to be explicit. My desire is there, but my machinery has changed. The friction on the outside feels like sandpaper right now, and the inside needs time to expand. Redefine foreplay. Because of the blood flow lag, foreplay for a postmenopausal woman isn't 5 minutes. It's 20 to 30 minutes, and it might need to start with a massage or kissing rather than direct genital touch. If the clitoris is hypersensitive, painful to touch, tell your partner, don't touch the button directly, circle around it. Use the flat of the hand, not the fingertips. The sandwich technique. Apply lubricant before you start anything, then apply more during, then apply a soothing moisturizer after to calm the tissue. You are sandwiching the activity in protection. I want you to leave this video with one clear message. Pain is not a price you have to pay for aging. The changes to your internal and external sensitivity are biological facts, but suffering through them is a choice. You wouldn't walk around with a stone in your shoe for 20 years just because you're getting older. You would take the stone out.
Whether it is the external burning of the vulva or the internal aching of the vagina, these are solvable problems. Talk to your doctor. Ask specifically about genitourinary syndrome of menopause. Ask about localized estrogen. Your body has served you well for decades. It deserves to be comfortable, it deserves to be heard, and yes, it still deserves to feel pleasure. I'm Dr. Emma. If you found this helpful, please share it with a friend who might be suffering in silence. Subscribe for more deep dives into women's health. Take care of yourself.